Welcome to the Diversity in Oncology initiative. I am Dave Craig, the co-founder of Grit Health and a two-time cancer survivor and currently a caregiver to my wife with metastatic melanoma. We are a part of this partnership with Bristol Myers Squibb because we believe deeply in amplifying the voices that aren't heard enough, and to share resources and to make sure that everybody has equitable and equal care. And so this program that you're a part of now is our fourth session, and we'll share information about previous sessions as well as all of the resources towards the end of this really meaningful panel conversation. Before we get underway, we have a special message from the Chief Medical Officer at Bristol Myers Squibb, Dr. Sumit Hirawat, and we're honored to share his words with you.
I'm honored to be with you for this fourth gathering of the Diversity in Oncology initiative. I'm very passionate about having the patient's voice included as we think about developing new medicines. Many times over the years, I've had the experience and opportunity to hear from patients once the drug was close to the market or even after its approval. But over the last few years, we have seen the patient's voice evolve and change. I believe we are at that cusp of trying to decipher how to best include the patient's experience in developing new medicines. And from my perspective, the most important time is right at the beginning, when the disease is diagnosed and the patient is making a decision whether to participate in the trial or not. What I've learned over the past 2 decades as a developer of medicines for oncology indications, it is important to hear what the patient's expectations may be from their participation in the trial and what burden that may cause them and their caregivers. We have seen that innovations in cancer treatment have impacted human lives in a positive way, both in a quantitative and a qualitative manner. It is important to listen to people living these experiences and using their personal stories to improve the future of medicines being developed, to ensure that all people have the same chance of a positive outcome. It is for that reason that all of us are coming together to hear the experiences and to co-create solutions that matter so much. I'm now happy to hand it back to Brian, who has spent his career in patient advocacy, early pipeline, and innovative medicines that has helped to transform patients' lives. Thank you.
Dr. Hirawat just gave me the opportunity to share some really exciting news with you. Brian Lee was our planned moderator for this session, and his wife just had their first baby. So Brian is home with their family. We're ecstatic for Brian, and so I will be starting the conversation with you today. Also really want to highlight for anybody in the audience that would like closed captions, we have that available for you today. Please feel free to pin that in the gallery mode if you want to be able to use the closed captions. We'll be sure to share all the love on the screens with Brian when he returns from this really exciting moment. Before I introduce our first speaker and move into the panel, we just want to share with you that according to ASCO's Diversity, Equity, and Inclusion Plan next year, they highlighted that in terms of diversity in oncology, there are only 13 Indigenous oncologists in the entire United States. And when it comes to Black and African American, there are 300 Black and African American oncologists in the entire United States. And there are 600 Hispanic and Latino oncologists in the entire United States. What that means is that there is one oncologist for every 115,000 of these individuals in these diverse communities. If you compare that to white and Caucasian oncologists, there is one for every 15,000. That is a 5x disparity in terms of people who want to meet with and interact with somebody who may understand their lived experience. and share some of those experiences. It is for that reason and so many more that we are deeply honored to have these panelists and all of the speakers in the previous 3 sessions to share their work and to share their life with you. Session 2, when we're going to put the link in the chat for everybody if you want to visit it, was the experience of diverse physicians and principal investigators in clinical trials. Dr. Sadhana Jackson is the only Black neuropediatric oncologist in the entire country. To hear her voice and all of the voice of those speakers is something I hope everybody will take the opportunity to listen. It is with that meaning and that profound significance, I have the honor to introduce our first speaker, Ana Velasquez. Ana, we are so grateful you're with us.
Thank you so much for having me, and hi everyone. I'm Ana Velasquez Mañana. I am a medical oncologist at the University of California, San Francisco, and I'll be chatting today with all of you a little bit about workforce diversity and why it is so important to follow up to David's points earlier. I'm truly grateful and honored to be talking to all of you, so I'm really excited to engage in our discussion moving forward. Now, I'm hopefully now showing my screen and showing the correct view. I see some nodding, so hopefully that worked. I'll present again how Leakgate really is the pipeline, and I think you really took it home with the prior introduction in terms of how disparate are the numbers in terms of representation of minority physicians in this country. And why is that really important? So there is a lot of data, both from business industries, from finance world, and also from healthcare, that shows that diverse teams really outperform teams in which are homogeneous, whether that's in gender, but also in race. And we know that in healthcare, in particularly, there are benefits related to patient outcomes, to patient satisfaction, to adherence with treatment, to the quality of care being superior when diverse teams and physicians, providers who share cultural similarities, background, language with patients are able to care for them. We know that there are tons of disparities in this country, particularly in health and in cancer care, from screening to across the spectrum. And some of them are driven by things like trust and related to historical atrocities that have occurred in this country towards communities of color, both Black communities and Latino communities. And that is a huge barrier for us to be able to really diversify and increase access to clinical trials, but not just to trials, but also to healthcare. And I want to highlight that, you know, we historically hone in a lot into trust as being a big barrier, which it is, but it's not just the only one. And I want to make the case for including the diversity of our workforce as one of the barriers. In the US overall, the issue is not just of oncology. This is the latest data from the AAMC, which looks at all physicians in the United States from all different specialties, showing you that the majority, more than half, are white, followed by 17% Asian, and Latinos represent only 5.8% of all physicians, and Black or African-American physicians are only 5%. So these numbers are extremely small, and we get even into smaller numbers when we speak about Native Hawaiians or Indigenous people. For specifically oncology, part of the problem is that training to become an oncologist and treat patients with cancer is highly competitive, and it is very long. There's subspecialty training. You have to go through medical school and continue through multiple barriers to what we call that pipeline that basically work as funnels in narrowing the amount of people that turn out at the end completing this specialty. And between all the different specialties that exist in medicine and treating adults, with cancer, oncology is the least diverse of all of them, and the one who has less underrepresented minorities and people of color compared to all the other ones. So here in this graph, in this table, is showing compared to gastroenterologists, infectious disease doctors, cardiologists, you name it, we are at the bottom. And that is something that has not changed over time, unfortunately, which is what the graph on the right is showing, in which we are this turquoise line on the bottom. Despite many efforts, really, we haven't made any leadway or change over the last 2 decades. So we did a project last year looking at specifically trainees or fellows, which is the last tier of training before becoming an oncologist, and trying to identify specifically is the issue that people are, after training, not going into academic practices in big cancer centers, medical schools, and going into other types of jobs, or are we just not enough? And as you can see here, between Hispanics are only 6% of current trainees, and African Americans 3.8. So the experiences of all of these trainees, similar to mine, is that many of us were the only ones in our institution. And for example, I train in UCSF, where I'm currently at, in California, and Latinos are almost half of the population of California. And I am the only oncologist that is Latina in my institution. And sounds horrible, but it's not rare, and it's not the exception. It's unfortunately more like the norm. This, as shown here, it's even worse when we get again into Native Hawaiians, Pacific Islanders, and Indigenous Americans. And one of the big barriers is that this represents really a gap when we look towards what is that pipeline and the percentages of trainees that advance through time. So here in this graph, we are comparing to the United States population, and in the latest census, Latinos are, for example, 18% of the US population and expected to grow, and African Americans are around 13%. So those numbers are very different to our practicing oncologists, in which is this purple bar are Latinos of 4% compared to 18% of the general US population, and African Americans are 3% compared to 13% of the general US population. If we look again on every single step of this training path towards becoming an oncologist, from being in medical school, going through residency, and completing training, and then practicing as a doctor, we can see, for example, that Asian groups tend to be overrepresented. So this orange graph line or bar becomes bigger, as well as white individuals, which are not included in this graph for the purpose of being able to show you how small the numbers are on the minority aspect. Between Indigenous and Pacific Islanders and Native Hawaiians, the numbers are even less. As you can see, this is supposed to be a pink, hot pink color line. It's basically absent because representation is so small at this point. So I think I've made at least, or show you data that I think it's quite clear that there are huge problems with representation and with having a workforce that shows and what the diversity of the United States currently is and will continue to be. And there's different ways in which we can approach this, and I'm just going to show some small efforts that are ongoing in trying to increase diversity in the workforce. And I think one of the most important things is mentorship and sponsorship, which is something that everybody can do, particularly people who work in healthcare, who are invested, who are in pharmaceutical companies, but even in communities. If you know somebody who is from an underrepresented background, who's interested in science and healthcare, who you can make introductions for, to get to know a physician, to go visit them or see them in their clinic, spend time with them, see what potential they can have in their life and career, I think that's still impactful. From the perspective of universities, of academic centers, there's still tons of things to do in terms of making sure that universities which primarily train and educate underrepresented minorities are supported, there's investment on them, and their graduates are treated as well as those who come from other types of universities. And then investment in pipeline programs, which are programs specifically built to support trainees from underrepresented backgrounds, whether those are racial or ethnic based, but also based on disadvantage from a socioeconomic standpoint, homelessness, and others. And I'm here highlighting only a handful of them, particularly sponsored by ASCO, which is our oncology society, because we are talking about cancer and cancer care and how to improve our cancer workforce. And between them, ASCO has developed over the years many different initiatives, which you can see here, that are sponsored, particularly tailored to addressing different steps along that pipeline. For example, the Oncology Summer Internship is a new specific program that they have built over the last year that we at UCSF are lucky to be part of, and that I'm currently leading, which provides exposure to what cancer care is for medical students during their first year of training. So medical school usually is 4 years long and is trying to get the earlier possible students engaged and excited about learning about cancer, about the research opportunities, but also the diversity of patient care that they can provide through the different specialties involved in providing care for patients with cancer. There's also opportunities and research awards that are related to students and residents that are invested in doing research in cancer. A diversity mentoring program that I'm also a mentor of, which similarly connects students throughout the United States from underrepresented backgrounds and medical residents with a mentor who may be a physician, a fellow, who shares their background to give them more of this life mentorship and perspective. And recently there's been the development of a couple of awards that are really key to skyrocketing and really building research careers for oncologists, like the ASCO Young Investigator Award. And during the last 2 years, Dr. Narjus Duma and Gladys Rodriguez, for example, have specifically fundraised to create one for Latinas, because Latina women, between oncologists and between medicine in general, are dramatically underrepresented, similar to Black men in medicine. There are other different efforts too invested in, for example, there's the YIA for researchers from also underrepresented backgrounds who are studying breast cancer disparities, which are specific similarly to try to advance DEI efforts and diversity in our workforce. So as take-home points, I think I've shown you a lot of data about how underrepresented women and racial and ethnic minorities are in oncology. And this is truly a call for action, for, I think, change and accountability from institutions, from our educational system, and from us as society, in ways in which to decrease barriers for people to achieve, their academic goals, achieve education, and any professional goals that they have. And for us to think of this really as a tool to increase cultural competency, decrease disparities, and improve patient outcomes, which is at the end of the day what we're most passionate about. So I'll stop there and I'll jump in over our panel today, talking more about patient-related issues, which I also, as an oncologist, of course, have some experience with. Thank you, David.
Dr. Velasquez, today is National Doctors Day, and we can't let this moment pass without thank you for the lives you are impacting today, and even the future of lives that will all be made better because of your legacy. So please, everyone, join me in thanking Dr. Velasquez and everybody who does this work.
Thank you so much, Earl. Too kind.
Dr. Velasquez, I know in our prep meeting, there was some really exciting conversations happening with you and the other panelists. And so I'm excited to get to those in the next part of the panel. So we'll come back soon, I promise. We are going to now switch to 2 polls to get some audience insight before we move into our next speaker, Courtney. And so, Jessica, may I ask you to put up the first poll question for the audience to provide some insight to? So our first poll question is, what resources do you think patients should have access to when considering a clinical trial? And you can select one or as many as you'd like in this question. Okay, so it looks like financial assistance is the highest response of these, followed closely by transportation services, language interpretation. I'm really honored to see that as high as it is. And of course, mental health and wellness. These are many of the areas that we're going to get into in this panel. And so really grateful that we have these speakers to share insights on this with us today. And Jess, we will move into the second poll rather, I apologize. And our second poll question is, patients are able to access the supportive resources they need in clinical trials. Do you strongly agree, somewhat agree, disagree with that statement, or strongly disagree? Wow. 55% of our audience said they disagree. 9% said strongly disagree. So combined 64%, almost 2/3 of our audience, feel that patients do not have access to the supportive resources they need. I selected strongly disagree. I've been an advocate now, this is my 10th year. And so for the panelists who are sharing the resources that you are next, you are meeting a really critical need. It is with that purpose and meaning, I am honored to introduce with you Courtney McHugh from an organization that has helped my life and so many personally. Please welcome Courtney.
Thank you so much, David. My name is Courtney McHugh, and I'm a licensed social worker and lead navigator at Family Reach. I just want to take a moment to thank Grit Health for the invitation to speak about Family Reach and our services, including all the resources that we provide, as well as thanking all the audience. It's truly a pleasure to join all of you today, as well as each one of the panelists who joined me here today. So I do want to start off with something different, a story. In your mind, imagine a family of 4. They are getting by in their apartment and are essentially living paycheck to paycheck. The parents struggle financially and they do everything they can to keep a roof over the heads of their children. Then one day, they receive devastating news. Their youngest child has cancer. Their son is 6 years old and has just started kindergarten. This is a scenario that plays out every day, and it's a story that Family Reach has become very familiar with. I can even tell you what happens next. Their son starts missing his first year of school. The parents focus on the treatment, the appointments, and drop everything and do anything to help their child. They start missing a substantial amount of work. They are motivated by the fear that can only come when a parent is told their child has cancer. But that's not all. Within a month, they are hit with a second wave of fear, one rooted in the financial reality that they may lose their home because of the piling bills. In a nutshell, this is the problem that Family Reach has seen play out for 25 years, and the reason every employee is motivated to help that family. When a loved one is diagnosed with cancer, so often finances really are just not top of mind. Families are grasping the fact that they've been hit with the words cancer diagnosis or you have cancer. And so that's where Family Reach comes in. We come in to provide financial support services to families facing cancer. And we try to remove those financial barriers standing between a cancer patient and their treatment so that a family doesn't have to choose between their health and their home. And how do we do this? We actually deliver what's called the Financial Treatment Program. Our financial treatment program is comprised of 4 key areas: financial education, resource navigation, financial coaching, and emergency relief. Today, I will be highlighting of the 4 key areas our financial education piece with a focus on our financial guidebook. The financial guidebook is used as a resource tool for families and caregivers to start having those conversations in unison with their healthcare professionals surrounding their finances. It's certainly not an easy conversation to be had, but it's definitely important. Inside our financial guidebooks, you'll be able to learn about cost-saving options, easy action steps to follow, checklists for estimating personal costs, advice from patients and other caregivers, as well as a list of other vetted financial resources. Currently, our guidebooks are available in 3 different versions. There's a pediatric cancer guidebook, which is for those under the age of 18. There's our young adult cancer guidebook for those ages 19 to 39. And then our adult cancer guidebook, which is for those over the age of 40. While the foundational information is the same in all copies, there were certain pieces of information that we felt were relevant to separate out and include in those specific populations. Additionally, I will say, as we're trying to reach more diverse populations and groups of people, we currently have our financial guidebooks in both English and in Spanish, and hope to expand this to other languages as well. Our financial guidebooks are downloadable from our website at familyreach.org under the green Get Help tab. Additionally, if a family or a healthcare professional submits a financial treatment program application on our website, if an email is provided, the family will receive an age-appropriate guidebook that will automatically be sent to them. The next few slides that I will be covering just talks about a little snapshot of what's in our guidebook. And here is the first page of what you'll see in our guidebook. And we wanted to really highlight all of what a family can feel, like I had mentioned earlier, when they hear those words, you have a cancer diagnosis. And one of our members during one of the focus groups that we held here at Family Reach had mentioned that at the time her loved one was diagnosed with cancer, she had wished that these words were said to her. And so it reads, "We know, overwhelmed, confused, sad, angry, whatever you're feeling right now, it's valid. We understand that you might not have the energy for more information right now. All we ask is that you take this guidebook home. When you're ready, it will help you manage your money to prepare for what's ahead. It doesn't have to be today, doesn't have to be tomorrow, or even this week. You don't have to get through it all at once. You don't have to carry any blame or shame. None of this is your fault. Just know that this guidebook is here to help." Further inside our guidebook, you'll see this resource key, which is broken down into 3 different topics, and it's associated with colors and icons, hopefully to make things a bit easy on you. Each indicate a specific type of financial resource to help a family pinpoint the most useful information at that current time based upon their biggest concerns and financial needs. Additionally, inside you can find a checklist of expenses for, let's say, those who have health insurance, and a breakdown of being able to estimate monthly premiums, their out-of-pocket maximum, and kind of get a big picture overview of expected costs. Certainly don't have to have those exact numbers, because I'm sure families are trying to take in all the information right from the beginning, so it can be overwhelming. So no need to fill in this information right away or have those exact numbers. Additionally, there's another table in relation to treatment-related costs that are not considered medical expenses that may come up for families. So for instance, this can be parking expenses, meals at hospitals, or even lodging facilities that may be out of pocket. that families can feel a sense of empowerment and plan ahead for these upcoming costs that they may not be aware of. And then there's another table also listed for those household expenses to keep track of. As the cancer community may be aware, while you're going through cancer treatment, the household incoming expenses are still coming through. And so being able to track these household expenses as well, hopefully arms families with knowledge, have some sense of structure to be able to hold onto what all these expenses may look like in the long run. Additionally, within our guidebook, there are insurance coverage options and information on specific laws and acts that are implemented into practice, as well as additional resources. Insurance coverage options such as the Affordable Care Act, Patients' Bill of Rights is listed, and more information on that, as well as employment laws such as the American Disabilities Act, debt collection practices, for example, the Student Loan Deferment Act, and as well as alternative options for, let's say, those populations of people who do not have health insurance. So listing out those alternative options, such as federal insurance programs, such as Medicaid, or to be able to navigate that there are free or reduced cost care through the hospital or health insurance or the marketplace. So being able to have this list of resources and information readily available for those different groups of people is always helpful, and that's within our guidebook. And lastly, just to sum this all up, I think what's really important is to know that with every family, you can't really ever plan for something such as cancer. It's completely unexpected. No one really does plan for cancer. And so I think in just being able to understand that, you don't have to feel embarrassed or ashamed to seek help or ask for help and utilize resources that are available, such as our guidebook. I think so often when we think of cancer diagnosis, it may be forgotten that financial distress is very well a common side effect that comes along with cancer diagnosis. And to know that to go at a pace that feels comfortable to you, to remember to be kind to yourself, and also to know that there is a team of professionals and trusted loved ones, such as Anna, your oncologist, or myself, or our other family reach resource navigators, nurse navigators, hospital social workers. So we're all here to lend a helping hand and to know that you don't have to do this alone. And thank you so much.
Courtney, what stood out so strong in that paragraph you read in the guidebook is the part about shame, and what so many people respect about Family Reach is meeting people where they are to destigmatize these issues. And you do such a wonderful job. I hope in the panel we'll come back to stigma and that piece of what you do so well. Thank you so much. We do have one more poll question before we introduce our third speaker. And so, Jess, if I can have you put up our third and final poll question for the audience. And the question reads, medical expenses relating to participating in clinical trials can be covered by Medicaid. True, false, or you're not sure? 60% of our audience says not sure, and the other is almost split in half between true and false. This is an area that I have to admit I did not know a lot about, and I am so grateful that our third speaker, Carrie McDonough, is going to bring some insight into this, as well as some research they've done to really kind of understand this landscape. So, Carrie, we're honored to have you with us.
Hi, everyone. You'd think by 2 years in, I'd be, down with the Zoom capabilities, but there you go. I'm here to talk a bit about the Clinical Treatment Act. And the reason why I'm here to talk about the Clinical Treatment Act is because it is something that I believe has gone, but I'm just trying to share this too, it's not coming up, gone unnoticed. And it's around, it ties into some of what Anna talked about, some of what Courtney talked about, really around the idea of making sure that we're making care, and clinical trials are certainly part of care, as inclusive as possible. So first, I'm Carrie McDonough, and I lead the Patient Voice Consortium at Syneos Health. And we're a company that works with biopharmaceutical companies, large and small, across the entire drug development and bringing patients into clinical trials, but also thinking about clinical trials and then what it means for the real world communities that are accessing the outputs of these trials in terms of medications that are then approved for care in the real world. And today I'm here to talk about one concrete way that we can work today, and actually that's actionable today, that can make clinical care a little bit more inclusive. If we can jump to the next slide, please. So first, a quick review of why representation matters in clinical trials. First of all, clinical trials are often the only viable or the most desirable option for folks that are, especially in the cancer community, folks that may have exhausted other options, folks that this is the most appealing avenue for them. Also, research requires diverse bodies. Just because a drug is tested in, say, an average size, middle-aged, middle-class white man doesn't mean necessarily that it's going to, work the same way in a teenager or in other subpopulations, communities of color, basic, gender. There's all sorts of different factors that impact how we may metabolize medications, how certain, especially with the era of genetic medicine, how all of that comes into play. So at the end of the day, inclusion and representation in the trials really leads to an improved ability to offer equity to those that are seeking options today, as well as offering more representative information and more specific or targeted information about how the medication might work for somebody in the real world. And there are many, many, many barriers to inclusive research and inclusive clinical trial design. Some of these Courtney and Anna have already touched on. Trust is huge. Resonance and relevance in terms of the way we talk about clinical trials is enormous. However, that's not the only thing. Also, we need to look at eligibility criteria, and based on FDA guidance recently, there has been a lot of emphasis, much needed and long delayed emphasis, on looking at eligibility criteria and trying to make sure that it matches as closely as possible, while also preserving safety and the viability of the research endeavor, but making sure that that eligibility criteria really matches the real world population. I mean, today a lot of, for example, people with HIV/AIDS are not allowed to be in clinical trials. I mean, it hasn't been very long that there's been much of an emphasis on even having women be part of clinical trials in a concerted effort. And so that's another key way. But then kind of linking to what Courtney talked about in terms of finances and resources, cost is something that we don't talk a lot about when we're talking about clinical trials. And I think that's, and I'm not alone here, it's a miss, because as we know, cost is huge. It's unfortunate, but the landscape that we have, cost and resources are huge when it comes to people and how they're making critical decisions about life potentially altering or life-saving care, and how they're doing that in a very, very, in a period where they're already highly overwhelmed. And so I'm gonna turn to the next slide, which brings me to that simple sort of thing that we can, act on today in order to at least help. And that's the Clinical Treatment Act, which is an act that passed and went into effect at the very beginning of 2022. And what it does is requires Medicaid in all 50 states to cover routine costs of trial participation for Medicaid enrollees. And until this year, Medicaid was the only major US payer, so the only major health insurance provider not required by the federal government to cover routine costs. Medicaid has been an outlier because Medicare and private insurance plans have been required to cover these costs for years. So just want to take a minute to just explain what we mean by routine care. It's the cost that somebody would have access to whether or not they were in a trial. So regular doctor's appointments, emergency care, those are the things that they consider routine. It's definitely standard and expected that sponsors, so the companies or the institutions that are doing research, that they cover costs related to the study drug that's being investigated, as well as any additional tests that would go above and beyond sort of what they would consider regular or routine care. So now that we've got parity on paper, let's dig into what that kind of means for, who are the folks that are in the Medicaid pool. We definitely see uneven enrollment across populations. Nearly twice the proportion of Americans who identify as Black, Native American, or Hispanic are enrolled in Medicaid compared to the Caucasian population. It's also a population and a service that's been designed for folks with either lower incomes or higher needs. 1/3 of individuals with disabilities receive Medicaid. And a recent analysis shows that 5 million of the essential and frontline workers, and that's not entirely healthcare workers, but a large amount of them are also recipients of Medicaid. So if we can definitely see sort of an overlap between the two areas, the Medicaid population and the folks that have historically been left out of many clinical trials. Next slide, please. So it's great, right? This has passed, and that's really great news, except that we all know in the advocacy space, especially, that awareness is everything. And like any policy change, the Clinical Treatment Act, it's not a panacea, but it's a step forward. But the only way it's going to be a step forward for real is if it's implemented at the state level appropriately and as the authors intended, and also that patients are aware. And so we were a little bit concerned when it was getting to be the end of last year and we weren't hearing much about this at all. And asking around, colleagues, advocacy groups that we're working with. Yes, it was the advocacy community, largely led by ASCO and ACS and a number of others that were at the forefront in making this pass. However, now they're very much steeped in a lot of other areas to make sure that they're protecting rights that patients have earned and rights that the community has earned for patients, including some of the Medicaid expansion work. And so there really wasn't much going on from a communications perspective. And so we thought, okay, maybe we're just missing something. And so we thought, let's do a little survey to see what physicians are thinking or what physicians know about the mandate, and also equally importantly about the financial barriers that clinical trial participants might be considering. And what we found, the most startling thing was only 1 in 5 physicians were aware of the mandate prior to the survey. What we also surfaced was a lot of sort of misperceptions about why Medicaid participants may or may not be right fit for clinical trials, some misperceptions about the cost of care in general, and realize that there's a lot of work to be done there on the physician front, which is, touches a lot on what Anna had shared just previously. But also what this struck us was, okay, if doctors aren't aware, how in the heck are patients going to benefit? And so in this community, we know that advocates can't always solely or even exclusively or often rely on the information that they're receiving from physicians. Patients, it's sort of hit or miss, whether they're going to get a physician that's going to sit and spend the time that it might take to explain what it means to participate in a clinical trial. It's hit or miss whether or not their physician believes they're going to be appropriate, and will even ask them if they're interested in learning more about a clinical trial. I mean, there's some really startling data about who actually gets asked to participate. And so we need to make sure that as much as possible we have more of a direct path to educating patients about what their rights are, which at the end of the day is what we're talking about. And that brings me to my ask for you today. If you can jump to the next slide. So it's really just about thinking about educating patients today on their coverage rights during clinical trial participation, trying to help correct any lingering beliefs about Medicaid coverage that because there hasn't been much in terms of education around this, correcting the any lingering beliefs that if you're in Medicaid you're not going to have this type of care covered. And then you can access on our website some free resources that you can share. We have two backgrounders, one that provides a lot of details and some of the findings around physician perspectives from the survey I mentioned, as well as a backgrounder just going into the details around the Clinical Treatment Act, what it means, what it can do, what it cannot do, knowing that, like I said before, it's not a panacea, but it is an actionable, concrete thing that can help fix at least one of these gaps and help make that treatment decision process and whether or not somebody wants to participate in a clinical trial, help give a little bit more power back to the patient and their family who has to navigate these tough decisions, in order to protect and potentially, help to prolong and improve their quality of life. Thank you. Packed a lot in there, but, and I apologize again for the tech issues, but thank you very much for the opportunity.
Thank you, Carrie. That's such an important thing we need to bring more attention to. And so excited to come back to you in the panel conversation, the Q&A just after this. Our next speaker, Candace, I'm personally honored to introduce you for several reasons. The reason I became an advocate in 2012 was not because of my own two cancer diagnoses. It was my dad's bladder cancer diagnosis. And I had been a researcher and a survivor and was overwhelmed trying to find a treatment option for my dad in clinical trials. It is what brought me into advocacy. And so for that reason, I'm honored to introduce Candace Howell and the work you're doing to the audience. Please welcome Candace.
Thank you so much, Dave. And thank you everyone for the opportunity to share and present on Bristol Myers Squibb Study Connect platform. As an engagement strategy lead with Global Development Operations, I focus on bringing the voice of the patients and caregivers into the clinical trial design and implementation. So let me share my presentation. There we go. So at BMS, we strive to bring meaningful change, improve the patient experience, and generate greater diversity in clinical trials. So through global expansion and innovative approaches, BMS has created an industry-leading patient engagement forum. Although Study Connect is not new, we have added several digital capabilities to support patients and caregivers before, during, and after their trial. Now, what is Study Connect? It is a leading patient engagement website for patients, caregivers, and health professionals. The comprehensive platform helps patients to learn about clinical trial research and find clinical trials in their community. I will share how Study Connect is dedicated to increasing clinical trial awareness, participation, and patient engagement. On the side, you will see this is the home page for the US site for Study Connect. Very inclusive, very engaging, easy to read. And again, this is because we received feedback from patients like you. We have three core areas that we focus on for the Study Connect experience. First, educating you about clinical trials and the conditions that we research. We have a call center that actually answers questions that are frequently asked by patients, caregivers, and loved ones. We have a glossary of terms and a list of support organizations on the site. Additionally, we have dedicated web pages for patients, for parents and healthcare professionals. Second, we're connecting patients directly to sites through the patient referral process, which I'll discuss a little bit later, and providing sites with potential patients through our screening questions. So that means we link you directly to the sites so that we have the follow through to ensure that you have support along the way. Again, before, during, and after your clinical trial experience. And lastly, we're engaging patients and caregivers through videos, stories, and again, as I referenced before, the call center. Now, this is an example of a study protocol page. Once you search for a trial and select a trial, this page will open up for you. And on this page, you can see you have the trial description, the recruiting status, the treatment options, eligibility criteria, and a map of trial site locations. You're also able to share this information with your family and loved ones, but then most importantly, you can share it with your HCP and have that as a talking point when you go in to speak with them about clinical trial options. Now, here's the screening process I was speaking about, I referenced earlier. We offer the opportunity to match you with clinical trial sites. And by completing the patient pre-screener, they will ask you questions related to your condition. After you complete the questionnaire, Study Connect matches you to potentially appropriate trials. And here's an example of a trial being listed here. And we would follow through with you and making sure that you have information that you need. But then also, one of the great things about this tool is that it does not only match you to BMS trials, it also matches you to non-BMS trials. That is an industry standard that we have set, and we're proud to continue to set it. Now, also we have the patient referral process, where that when you complete the patient screener, your information is shared with the site so they can follow up with you. You receive an email confirmation, the BMS staff receives an email confirmation, and then they will follow up with you to ensure that to follow up with you to see if you have any questions about your participation or going to the site so that we have that follow through for you. Again, we are here to accompany the patient through the process. And finally, our call center. Our call center is supported by a vendor called Pharma Centra. They support calls from the US and Canada in English, Spanish, and French. Additionally, they support emails globally and the same 3 languages. We are happy to have this call center because we want patients to have a resource to go and ask the questions that they may have that might be on their mind. Now we talk about our commitment to diversity. BMS remains committed to diversity and inclusion. And these are the ways that we have done it within BMS Study Connect. First, we have patient-centered language that puts the patient first. Second, we have an internal diversity and clinical trials advisory committee. This committee is comprised of diverse BMS colleagues that provide feedback and insights on what we're doing within BMS Study Connect. Part of that included ensuring that we had diverse imagery and content on our website. Ensuring that our patient-facing recruitment materials were inclusive of those of the communities we're trying to recruit. Additionally, for BMS Study Connect, we have dedicated country sites translated in the native languages for those countries. We also feature stories on diversity in clinical trials and resources from patient advocacy groups such as yours. And coming soon, I'm so excited to announce, we're actually going to have a banner on each web page highlighting our commitment to diversity so that when patients come to the site, they now know that we are truly committed and we're going to follow through in everything that we do and our commitment to the patient. And then finally, having dedicated diversity page with online resources for patients to know that they have resources in their community to support them through the clinical trial process. And as we saw in the survey earlier, is making sure that patients know that there's the availability of resources. And this is a place that you can come to and find out about those resources. Again, walking with the patient as they go through the journey. And as I've mentioned previously, we have the global sites. And so I wanted to show off a little bit about our global sites. We have 17 countries and 13 different languages. And France is coming soon, so we're excited to have them be part of our footprint. But this says that for patients that are located outside the US, there are resources. There is a Study Connect that again can match them with clinical trials, BMS funded and also non-BMS funded. And this is just a summary of all the features I highlighted. I wanted to make sure that I highlight the key points. But first, you learn about the clinical trials that we have ongoing. You can search for clinical trials using keywords, study numbers, and locations are close to you. You can answer the pre-screener questions to find the best match trial for you. Additionally, you can view and print those clinical trial details so that you can share with your loved ones and more importantly with the HCP to initiate that discussion around clinical trial engagement. You can follow conditions, trials, and clinical trial sites and receive email notifications. You can register at participating clinical trial sites to be contacted directly from the site location. You can find frequently asked questions, support organizations, and a glossary of scientific terminology that you may not be familiar with. And finally, we have a dedicated call center to help you along this process that we're committed to be with the patient. I thank you so much for this opportunity to share this presentation.
Thank you so much, Candace. I don't know if you saw Joelle's comment in the chat about how important this is because of being made to wait when trying to find treatment options. And, you know, if we put ourselves in the patient's shoes, waiting weeks is forever. And so to have resources to reach out to and connect is just so powerful. Thank you.
Thank you.
Wonderful. All right. And oh, and by the way, in the chat, all of these resources are being included as we go. They will be available on the platform afterwards. So if you're looking for any of the specific links or want to refer anybody to it, it's all in the chat and it'll be on the platform. Okay. And we have a really important final panelist, Terry Brisker. I've known you for a couple of years now, and the work you do in mental health, destigmatizing it and really making people feel human about these journeys is just incredibly important and moving. I'm honored to introduce Terry Brister to you.
So I'm the Chief Program Officer for NAMI at the national organization. Who we are is a group of 650 different state organizations and affiliate chapters across the country. And again, you may be thinking, why is NAMI part of this presentation? You've heard some of the other presenters talk about the mental health component, but mental health conditions and what people who receive that diagnosis of cancer that Courtney, you mentioned earlier in your presentation, have some real similarities. So I want to ask you to think for just a minute, not about oncology specifically, but about people just in general. And let me walk you through who we are and then talk about why I'm asking you to open your mind for just a minute. So again, we are a group of about 650. We've got probably 200,000 members. We're a little bit of everywhere. We're not in every community, but I like to tell people we're kind of like a spider web. We're similar to the Heart Association or the Cancer Society, if you will, that there are organizations in each state and in communities, and we do 4 basic things. You can look at them as buckets, or you can look at them as legs on our stool, but we really do 4 different things. We advocate for research. We raise funds for research, typically around mental health conditions and neurological conditions. But it's also about how those conditions intersect with others. We provide education, we provide support, and we provide advocacy. And you've heard every presenter today talk about the need for advocacy in terms of payments, in terms of parity of service availability, the inequity of first of all, the shortage of treatment providers across the country in all the spaces, and the extreme shortage of providers who look like us, whatever the us happens to be. And that's true across the board. So those are the 4 big things that NAMI does. But why am I here? Why am I here talking with you today? Why is this important? It's important to be able to drive the slides. At any given point in time, 1 in 5 adults are experiencing symptoms of a mental health condition. We all go through, we all have bad days, we all have bad moods, we've all had grief reactions to something that maybe we worked through relatively quickly. When we talk about mental health conditions, we're really talking about something that's more pervasive, something that interferes. The symptoms are to the point that they interfere with your ability to function at work, at home, at school, those types of things. So again, 1 in 5 adults at any point in time. We know that 60% of adults and 50% of youth who have a mental health condition never get treatment. They never go for treatment. A big part of that is stigma. The stigma around having a mental health condition, the stigma around having a chronic condition. You see the number on the bottom of the slide. Suicide is the 2nd leading cause of death among 10 to 34-year-olds, and the 4th leading cause of death among 35 to 54-year-olds. Again, stigma applies to not just getting mental health treatment, but it applies to clinical trials. There's a stigma attached to asking for help. There's also fear and distrust. You can tell I have a little bit of an accent. I'm in Mississippi. There is a very deep distrust of researchers and clinical studies in the South, particularly in the Black community. But we're the Bible Belt. There's a distrust of science here. So you have those stigmas as well. The virtual world has helped a little bit in terms of allowing us to reach people virtually without people having to come in personally for support services and for education services. But given everything you've heard from the previous speakers, I want you to think about it now from the perspective of not just a mental illness and not just a diagnosis of cancer, but think about co-occurring conditions. Very seldom does someone just have a mental health condition. There's almost always something else going on. Receiving a diagnosis of cancer is catastrophic. We teach in our education programs that learning you have a mental illness is also catastrophic. And we respond pretty typically to catastrophic stressors. They're things we weren't ready for. We really don't know how to respond to them. We don't have any experience with them. And we're really not sure what the rest of the world is going to think about whatever it is. Whether it's our employer, whether it's our family member, whether it's our religious community, whoever it happens to be, we're just not really sure how people are going to see us. So on top of having physical symptoms and mental illness symptoms, you also have that extra level of social angst that comes along with it. So it can end up being what we call at NAMI a problem pileup, where it's kind of like pouring gas on a fire to have that second diagnosis or to have the diagnosis of cancer, and then you begin experiencing the mental illness, the mental health condition symptoms that are causing you trouble. Typical normal responses when you're faced with a catastrophic diagnosis like cancer, but they can become problematic in and of themselves. And it's kind of like pouring gas on a fire. You know something's going to happen. You just don't know how big the something is going to be and how much more complicated it's going to be to get things under control again. And you see on this slide, it just kind of becomes a feedback loop of the symptoms building on each other, and it gets into the problem pileup that I was talking about. If you think about physical health and mental health as being think of it as a circle. Each affects the other. One is not more important than the other, and they can both feed and make the other. Good mental health can help you be able to deal with other physical conditions that you're going through. But by the same token, having trouble with your mental health can interfere with your ability to get better and to improve with the other physical conditions. So they really are so interconnected. It's a balance. It is what it is. It's not fair. It stinks. But the biggest thing is to be aware that it's there and to be aware that there are things you can do about it, not things that will fix it, not magic things that will make it go away, either one of them, cancer diagnosis or the mental health symptoms, but things that can help you feel so not alone. Both of these illnesses, regardless of the specific type, the specific variety of mental illness or of cancer, you can feel so alone and so isolated. Finding support, finding help, finding a way to navigate the resources. Almost every speaker today so far has talked about one of the challenges being, how do you find? How do you pay for? Where do you go? And that's a place where NAMI can help. We have a helpline that you can reach, and you see here there's a chat feature on our website. There's also a 1-800 number. We have a relationship with the crisis text line where you can text NAMI to the crisis text line and reach someone. We have expanded our helpline hours during the pandemic from 10 a.m. to 10 p.m. so that there's to accommodate the East Coast and the West Coast. And we'll be adding the chat feature we'll be adding a text feature. I'm sorry, chat feature we added last year. We'll be adding a text feature soon. So you can find support right now today. Just, where do I go for help? Who do I call? Who's available in my community? How do I apply for disability? What does Medicaid cover? We don't have all the answers. We can tell you what we know, and then we can point you in a direction to find the answers. And if I could click my slide, that would be great. There we go. You can also go to our website, NAMI.org, find your local NAMI and find the NAMI that's nearest you. Even if there's not one in your community, there is one in your state. And they'll have more information. Sometimes it's even, ask for Terry when you go to the Medicaid office in Jackson, Mississippi. She's really good with folks who are having trouble like we're having. Little things like that. Just talking to someone who's walked that same road can make so much difference. So you can find the NAMI that's closest to you or your state. You can go to our webpage and click on where the arrow is pointing, support and education. We offer family support groups for family members of people who are experiencing mental health symptoms. We don't care about the diagnosis. We don't care about how long they've been having trouble. It doesn't matter what else is going on. It's support for family members who love someone who's having difficulty. We also offer support groups for the individuals themselves who are experiencing the difficulties. And we also offer education classes, helping people understand that this isn't your fault. It's not something you did or didn't do. And most importantly, to help people find hope and hang on to that hope, which can be even harder when you're also dealing with something as devastating as a cancer diagnosis. So David, that's a quick run through, and I have a couple of resources that I made available to David and to Emily that they'll be sharing with you. And you can also find them at our website, Navigating a Crisis, and a family guide. What do you do if you're a family member? What do you not do? How do you keep from making things worse? And most importantly, I want to thank all of you for joining the call today and what you do every day to take care of the people that you are trying to support. Thank you, David.
Thank you, Terry, so much. We'll make sure these are available on the platform for anybody. And we hope everybody here shares these resources with anybody that they might be helpful for. Okay, we've got just under 15 minutes for some audience Q&A. And what I'd like to do is ask anybody that wants to ask a question of any of our panelists to please put it in the chat. And to actually start the conversation, I have a question, Anna, if I can ask you, there we go. Let me get you up on the screen. Oh, wait, there we go. Thank you. So Anna, we talked about something in the prep that really affected me deeply. One of my mentors, Sheila Thorne, has been a multicultural advocate her entire life. And she has said that we cannot leave diversity and supporting diverse individuals up to diverse individuals. We all have to be active participants, and we can't overburden certain individuals. You have an audience of people here who care and want to be a part of the solution. what can we do to support diverse individuals in cancer and in clinical trials?
Thank you so much for asking that question. I think that is, I mentioned it during the prep because it's something that is important, that is a lived experience for people like me and like others on this call. And that I think over the last 2 years also has been aggravated and increased as we, as a nation, become more aware of the impact of racism that has had for centuries. I think that for everyone, the number one thing that we can do is, one, become educated and listen, and really listen to the stories and the experiences and perspectives of people who may have different opinions and different backgrounds, to really understand where patients who have different cultures, who speak different languages are coming from and what their challenges are. We need to listen. And there's not enough voices out there represented in space, in any space, in advocacy, in clinical trial design, in healthcare in particular, nowhere. So I think for anyone who is in a position of power to bring others who have different lived experiences to be members of advisory boards, of patient advocacy organizations, to create spaces for those who may not speak English or who may not be able to access the internet, is really important. And it's something that it's not healthcare only that is going to do it. It's not the physicians, because we don't have the tools to do it. Particularly number one, not only that in general is not what most physicians do, but we don't even have the tools to do it. So I think that's where I would start. I can go on and on for a longer period, but I'll stop there.
Oh, that's so important. Candace and Carrie, Candace, you and your team at BMS, and Carrie, you and your team at Syneos, and our team at Grid Health, we all spend a lot of time listening to patient experiences and patient voices in clinical trials. We had a participant share with us recently that he's in a clinical trial, but has chosen not to share it with his immediate family members. And hearing stories like that of the human choices people make and why, Candace, what is your thought, hearing these stories and doing the work that you do?
And this is why we partner with patient advocacy groups, because we need to get those insights so that we can improve that process. I had a great opportunity to participate in a patient advisory board on Friday with several patient tags, I should say, within the oncology area. One of the things they talked about is we need to make sure patients understand we're not treating you, we're not testing you, we're testing the treatment. And having that education, understanding that we're here to support you, we're here to be with you through this process, but also understanding it's not, I think there's misnomer of how that trust is enabled. And as a result, they're afraid to tell their family members. It was also repeated on Friday that similar sentiment is true for other patients, that they're afraid to tell their family members because how they're going to be viewed upon, especially patients of color. That they're going to, and then you have the negative people sharing their negative thoughts and insights about it, because it's just what they have been raised to believe. But this is why it's important for us to get the right information out there to answer those questions, have those upfront and honest discussions about clinical research, and understand what it is involved. And that is the family approach will be helpful, that there are resources so you don't feel alone. There's online communities that you can talk to other people. But we definitely encourage patients to really share this and bring other people into the process with you so you don't feel alone. And there's ways that we can do that is by partnering with patient advocacy groups. Carrie?
Yeah, I would just add, sort of building on both of what you just said and what Anna said. I think the other thing that we can do, that everybody can do, is hold ourselves accountable. Mm-hmm. Sometimes, it takes a little bit longer to make sure that the group that you're bringing together for a patient advisory board or a expert summit or whatever it might be is diverse and representative of the real world patient population. I mean, there's projects, I mean, Dave and I and the grid team are working on a project where that's exactly the case, because sort of the usual suspects are people that have, you know, been sort of engaged and have been sort of at the forefront of, frankly, health advocacy in a lot of ways. You know, the folks that have started a lot of the foundations have represented a very like small portion of the population. And so I think it's all of us holding ourselves accountable to, you know, metrics and to sort of do the heavy lifting and do the work that it takes. You know, look at our SOPs, look at our plans, look at the way that we're measuring, you know, from a clinical trial perspective, look at, you know, how are we kind of gating when we're getting folks into trials to make sure that there's room for everybody, you know, so that it's as representative as possible. You know, doing the work, I think, is just the key part, and listening is work. Sometimes I think people forget that and they want to just run right to the solutions, but, you know, solutions come, you know, by and for the community. So.
Really well said. And that reminds me, at GRIT, we have what we call the GRIT Project. And so if there's anybody in the audience now or in the recorded version that wants to share their voice, may I ask our GRIT team to put the link in there. We always want to hear from individuals and to learn more. And so if you're somebody that would like to share your experience and share your voice, you can also read the other blogs and patient stories and things on our site. But please check out the GRIT Project if you're interested in sharing your experience. And I wanted to piggyback, Carrie, right on that. I love that Catherine Grimes in the chat said, well, why in the world wouldn't Medicaid cover expenses? And what that makes me think of is it wasn't until 1993 that it required a clinical trial act to actually mandate that women and diverse individuals are included in clinical trials. And it had to specify that additional cost is not a reason to exclude them. That was 1993. And so when we think about how recent these things are and how far we have to go, we need everybody's voice. So I'm so grateful you shared that. Any other panelists? Courtney, I wanted to make sure we had time to come back to you and the work you do, you know, in humans' lives. How is it for you guys in the community making this difference?
I definitely don't want to speak on behalf of every employee at Family Reach, but I do think we're all driven, honestly, by just compassion, collaboration. I think as being one of the navigators at Family Reach, it's a great honor, and being able to have that opportunity to connect on a deeper level with a patient or a caregiver that is going through a cancer diagnosis over the phone, or even by email, just being able to have that human touch to understand, you know, hey, here it is tough. I don't know how to navigate that. I think we all jump at that to want to do more, want to help. I think Angela posted in the chat, you know, there are resources. How do I get those resources? I think Family Reach, we try to provide these wraparound services, not just including the guidebook that I mentioned today, but all of those other resources that we do provide, including the emergency relief piece and making sure that it is easy. Our application is easily accessible through many different referral channels. And so similar to what Terry had mentioned, how you can call in, or there's the soon to be chat feature with Family Reach. We try to make sure that families can access us, whether that's giving us a phone call or connecting us by email, or submitting a direct application, whether that's the family submitting the application or their HCP and working collaboratively with their HCP. It truly is such an honor and a great feeling to be able to work with these families and to really see, you know, that to validate them and to have them know that their voice too matters, and they're a big part of you know, all of this change, and not just on a micro level, but on a macro level as well. I think that you know, I think with Family Reach, our emphasis is, I don't think I know, but it's that financial, having that financial conversation be a standard conversation, standard cost of care. So I think that, as we continue to reach other populations of folks, that this continues to be top of mind.
Thank you. I see the work you do firsthand, and it's remarkable how you help people move on that journey. Terry, can we just, before we wrap in a few minutes, you mentioned hope several times in your comments. What is it like to see someone in a dark place facing all these issues find hope?
I suspect everybody on this call has seen that happen and knows what it feels like. It's everybody who's involved in the work. I think that all of us do. We hear something similar. If I can make one person's life a little bit easier, and if I can help, if I can diminish, if I can reduce one person's struggle, even if you know something can't be fixed, knowing that there are other people who've gotten through it, David, and it's worth hanging on, and there is something on the other side of this, is just, I mean, it's what keeps us going. It's life affirming.
Sorry, I was muted that time. I want to save a couple of minutes to share a resource and then an ask at the end. But before we leave that, I just want to thank you, our speakers and panelists, for the work that you do and sharing it with this audience. Terry, you said helping one person, move in that direction, and we do that across all of these lives. It is truly changing the world. And so Anna, Terry, Candace, Carrie, and Courtney, thank you so much for sharing your passion and your work with us. I hope everybody in the audience will give you a round of applause in the chat for the work that you do. I want to make a very intentional transition. And so this is our fourth session in this Diversity in Oncology program. And I want to share with you the diversityiноncology.com platform, which is where we're compiling all these resources, and all of these sessions that we're creating live so you can let others know about it. I just want to share with you how this journey started. And if you ever have a moment to watch this short video, it is from Hong Tang. And this initiative is her idea within BMS. She has been at BMS for 25 years, but her purpose started when she was 6 years old, when her mom came to her and said, "Grab your favorite teddy bear in a bag. We're never coming home again." And that was just before the fall of Saigon and her coming to the United States. And she has had so many people help her on her journey and then dedicated her career to making a difference. And this initiative is her way to give back to other diverse individuals to have opportunities like she has. And so we need to honor Hong and this team within BMS, Catalina, Maurice, Candace, Allison, Lorena, Jennifer, Sarthak, and so many others. You have brought this program to life with us. And so just want to thank you for the character and the compassion in creating that. It's an honor to work with you on this. And what we're building, and this is the last piece I want to share, is all of these resources. So if you visit the platform, everything we've compiled now is listed here. You can search by resource type. We talked about financial support, education, clinical trials. These are all of the organizations. If you have any resources that you want to add or that are missing, please let us know. And I want to save a couple of minutes before the end of the meeting. We have a couple of survey questions that will help us understand what you are gaining and what we can all do better. And so I'd like to just have you close the meeting in just a minute. The survey link will pop up automatically. And if you could just take 3 or 4 minutes, it will help all of us improve our work. With all of our panelists, with Bristol Myers Squibb, with our team at GRIT, thank you humbly.